Melissa Singleton, and I'm Chief Programs Officer for Home-Centered Care Institute. So let me share with you a little bit about the previous sessions that we've hosted. We started last June with Bridging the Gap with home-based primary care, and the whole idea of this series was that we would help provide more integrated home-centered care to homebound and home-limited patients in Illinois. The idea was that during these sessions, attendees will get to explore the benefits of home-centered care, including home-based primary and palliative care, and how to successfully bring those models together. We continued in September with the intersection of home-based primary care and palliative care. And in December, we had a great session on optimizing efficiency in house call operations. I'm going to stop here and go a little off script. Have you ever thought about the power of the word "and"? By definition, it's an additive, added meaning, added value, added relevance, and let's be real, sometimes added work. But if you're in a hospice organization today, what would your business look like if you didn't also have and palliative care? How diminished would your organization be in being able to care for seriously ill patients? And what would the impact be on the number of lives you have had the opportunity to serve? We developed this series with these questions in mind because with funding from the Elia Institute, we wanted to ask you to come and learn more about something else that may be missing, another and home-based primary care. When we first started the series last June, we described how home-based primary care can help bridge the gap experienced by many patients who are seriously ill, homebound or home-limited, but maybe not ready for hospice. We talked at that time about the benefits of something we called a complex illness management model. And we said, what can this model do when you bring together home-based primary care, home-based palliative care, and hospice? You have the opportunity to serve a broader population and offer additional revenue opportunities like CCM and TCM. You can more fully meet the needs of patients and caregivers over time by coordinating their medical services. And you can focus on what matters most to patients: symptom management, caregiver support, and advanced care planning, and then offer appropriate and timely referral to hospice services. So that's what brought us to today. And when we talked about the power of and I acknowledge that and means extra work too, that's why we come together with you at Home-Centered Care Institute to be able to offer some help with that. But for tonight, let's go on, and I've shared a little bit with you about what we do at Home-Centered Care Institute. Again, education like this, but also online education, shadowing opportunities, tools and tip sheets. You can find a lot of information up here. Consulting services, research and analytics. That's something that's still relatively new, but if you'd like to sign up for a demo of Confer Analytics, which offers some business intelligence around the home care market, I would encourage you to take a look there. And we work with a whole host of partners on advocacy. We have our HCC Intelligence Resource Center, which offers tools and tip sheets and webinars and other resources to help you along the way. So you are not alone. I guess that's the bottom line here. You've come together with your peers and with faculty experts and the Home-Centered Care Institute, and we're all here to help this process. All right, so what are we doing tonight? The focus is on demonstrating value of home-based primary care services. And so at the end of tonight, you should be able to list the various payer types that are relevant to home-based primary care and home-based palliative care and distinguish between the characteristics of each. I want you to be able to identify the key individuals to connect with when negotiating contracts and demonstrate the value of your home-centered care services, whatever that looks like today, through presentation of quality of care metrics, utilization and outcomes data, and compelling patient stories. And I'm delighted to introduce our faculty. We have been so fortunate to work with really, really great experts across the country. Joining us on Zoom is Dr. J. Cameron Muir. He is the founder and principal of Cameron Muir Consulting and Chief Innovation Officer at the National Partnership for healthcare and hospice innovation. He's a nationally recognized physician and educator and executive leader in hospice and palliative medicine and advanced illness care. And I know you're going to just learn a ton from him. Amanda Tufano is here in the room with us, and she is the CEO of Genevieve Healthcare, or Health System, excuse me, and she's also a board member at the Minnesota American College of Healthcare Executives, ACHE, and the Minnesota Association of Geriatric Inspired Clinicians. So she holds a Master of Healthcare Administration degree from the University of Minnesota and is double board certified as the fellow in ACHE and the American College of Medical Practice Executives. And again, I know you're just going to learn a ton from her. And finally, Dr. Paul Chang, who, in addition to his role at HCCI, is the medical director at Home Care Physicians, which is part of Northwestern Medicine here in the Chicago area. He has made, I know it's over 38,000 house calls, right? I always have to keep changing this number. And, but just absolutely a pioneer and an expert in doing house calls in this country. And so I look forward to having him share his wisdom with you. We're going to go ahead and dive in, and I'm going to ask Amanda to come up to the podium. Cameron, we can see you on the corner of our screen. So why don't I let you guys take it away?
Oh, I tried CrossFit this week, and I can't feel my legs anymore. Anybody do CrossFit on a regular basis? Views, come on, get out of here. All right, I think Cameron's going to kick us off, and I'm gonna do the arrow directions here for a little bit. But I'm super excited because most of the questions, I think we're going to cover all the specifics that you guys talked about, so that's super good. And being longtime faculty with HCCI, let me make one more plug for the HCCI Learning Plan. That is super important. HCCI uses that data, anything you jot down, but it's also for you guys. It's just incredibly valuable because you pick up these tidbits and you're like, what did I learn? When did I learn that? Where did that go? And so I like that they kind of create a structure for remembering things. I've always enjoyed that. So, all right, Cameron.
All right, Amanda. Well, this should be a lot of fun. I first want to just begin by thanking HCCI for the opportunity to be with you all tonight. I was sitting in the classroom where you are pre-pandemic a couple years ago, which was the beginning of what I didn't realize at the time was my sort of transformation from fee-for-service hospice and palliative medicine into value-based primary care and the continuum of advanced illness care. And HCCI has been a fantastic partner for us at NPHI as well as for other practices that I've been doing, a lot of work with over the years. Great to see Sarah Dado and the HAP Foundation in the room, and all my HCCI friends. This is really great. And we're going to highlight, I think, for your business development colleagues at HCCI, some of the great values, I think, that the value that HCCI can bring to your practices as we roll through here. Amanda, I'm just going to start right off by saying I owe you something because I have this strange feeling you're going to have to be advancing the slides because I don't have a clicker over here.
Any Target gift cards work fine. DoorDash works fine.
Sounds good.
I'll send you my address.
DoorDash, okay. Good, please do. Yeah, or just Venmo, whatever.
Yeah, that's right.
That's great. Yeah. So we're going to review a couple different payer models. I think part of what I've been using in the language is understanding where the puck is going, and that's P in puck, not to be confused with anything else. And you can sort of, honestly, I think almost divine some logic that gets at a lot of the questions that you're asking if we look at the different payer types, and particularly CMMI and a bunch of the models that Medicare has put out over the past couple of years, the past couple decades, actually, and we'll talk about some of those. And that'll then, I think, help us to talk in pretty good detail, I think, about two of the models in particular, and we'll touch briefly on a couple of the others. And look at some of the main attributes of model requirements. Again, there's a risk, I think, and a huge opportunity. There's a risk as we get going, because Amanda and I are wildly passionate. All of us that have the privilege of working with HCCI are just wildly passionate about literally any model that will help us to more efficiently and effectively deliver the great care that people deserve in their homes. And I think if we get stuck in details, we'll want to make sure we pull back up and out and kind of divine some truths that I think are, again, go into all these different attributes of different models, but there's some themes that I want to make sure we pull out for you all from those details, and really just how to help practices transform. So I stumbled across this slide a couple years ago, and it was one of those things where if you can sort of see the whole mountain, for me, at least, I find this slide super helpful. And interestingly enough, this is actually in the public domain, but if you look at the small print at the bottom, it's actually from Humana.com. You may have heard of them. They're a small insurer based in Louisville. And what I love about this slide, and I do want to spend a couple of minutes, and by the way, if it's not ridiculously cumbersome, Amanda, if there are, just burning questions that people have as we go through this, because this is really literally the kind of the entire, well, a rendering at least of a view of an entire mountain. For many of us, especially me, maybe the only one with that much gray hair, my whole first numbers of decades, which actually my fellowship and first faculty job were there in Chicago. I think, Paul, I can't remember whether you were there at that time. I think I might have come and gone, but both our kids were born in Chicago. I was sprinting around with Northwestern's hospice and palliative care program at the time, both in the hospital, but also making lots and lots of house calls for people, particularly in home hospice in the Chicagoland area. So in some ways, while I'm not physically with you, it's really a treat to be in Chicago or around Chicago with you all. Sprinting around doing fee for service. That's on the far left here. And if you kind of hear this transition, and we'll talk about a couple of features, that fee for service is really volume. And again, we'll touch on this, and if you have questions, we can come back and dig deeper. And the distinction, if you look at the bold language or letters on the left, is volume, right? So you just keep the meter running on volume. And many have demonstrated that there's not necessarily an association between volume and quality. And in fact, in our country, we, particularly in the advanced illness scenarios, end up generating a lot of volume in the ICU and hospitals on people with multiple complex chronic conditions. And so there's been concern, I think, across at least certainly all the payer landscape that we need to somehow or another change the paradigm. So if you jump all the way over to the other side of the slide, the phrase is, value-based care and value-based payment. So value-based care and payment models. And I think it's helpful to just kind of, again, we'll get into details for half a second and come back up out. Value as defined in these models is generally thought of as raising quality, the numerator, over maintaining or ideally reducing costs. So raising quality while reducing costs. So you increase value by raising quality and decrease costs, not by just keeping the meter running and seeing more people. And part of this is a huge change, which is culture, practice, all sorts of shifts, which is, I think, Melissa, it's more work for sure. But it actually, as we come through this, has the opportunity to really allow for payment models that support the care models that many of my colleagues have said, thank goodness we're finally getting opportunities to be paid for the things that we either wished we could have been doing or have been doing but not getting reimbursed for. So if you kind of just quickly, if I scroll through left to right, and this will then jump into one more slide before we start looking at a couple of models. The bottom line is you go from left, which is fee for service plus, and you see here no risk to the provider organization, and you should report on a quality measure. And we'll later on this evening talk about some of the opportunities or at least logic that's been applied around quality. The big buzz acronym that comes in here is PMPM or PBPM, per member per month, or per beneficiary per month. The notion being, rather than if you do an initial H&P and 4 follow-up visits, that's 5 total billable encounters, that's volume. What they will do is think about a framework of saying, well, if we wanted to bundle all of this together and pay you a lump sum per month, per beneficiary or per member. Again, that was introduced, and examples of that are at some of the MA frameworks. Again, not necessarily any risk, and there is oftentimes at least some sort of a nod to quality. I'm going to give you my somewhat jaded view on that again a little bit later. Then you get to PMPM plus a quality bonus potentially. Again, no risk, but there's an upside. So you only have an upside, no potential downside. What you can see again, so you can start to see. So that's great. That sounds good. We can get a PMPM. If we also drive good quality, we can again come back to that later. Then there's an opportunity for an extra payment when they true up at the end of the year or whatever the look back period is. Then started to get into some of the financial models where it's not just quality, but there's an opportunity again, upside only for the PMPM plus some shared savings. And what you can see here, right, is kind of, when you put the lobster in the water and then you turn the water up, the lobster doesn't know it's boiling, but the risk is actually increasing along the course here. So there's an upside opportunity for shared savings, no downside if there are losses. And then we're going to talk a little bit more about the far right here and experiences that again, I had the privilege, honestly, of being thrown into a high needs ACO REACH. And we'll talk a little bit more about that, where there is in the global version, there's two versions, professional and global. In the global version of ACO REACH, there's 100% upside. So if you save $100, you can potentially get $100. There's also 100% downside risk. So if you lose $100, you lose $100. You lose $100,000, there's an asterisk around reinsurance, but you lose $100,000. So it really is a oftentimes referred to, or another acronym you'll hear is TCOC, total cost of care model. And the idea here is previously, if you're going on volume, just to kind of put it in, again, one other phrase in the context, and then we'll again start digging into some of these models, is you're going from relatively little accountability. I keep the meter running on the fee-for-service side. And if the outcomes aren't that great, we're sad and we hope we don't get sued. And I'm, again, hyperbolizing to make a point, but there's no risk. And as you go, and the word that you are familiar with, right, there's no accountability. And what this is really doing as you start going from left to right is increasing the risk, increasing the accountability for ultimately both quality outcomes and cost outcomes. And that is where the work has been over the past many years on, again, driving value, that critical word. So here's next slide, please, Amanda.
So
Cameron,
can
yeah,
I?
please.
Yeah.
Please,
Okay.
please.
Yep. I was gonna say, for me, I consider all of these other than fee-for-service value-based care, and sometimes it's inching your way in. So a couple of you ask about conversations with contracting with payers and key metrics, and we're gonna get to quality metrics. But as you think about contracting with payers, sometimes these make sense because of volume, right? You don't have enough volume to be in global risk, and so as you think about kind of moving towards like the PMPM or trying something new or doing carve-outs or things like this, I wouldn't say that the global risk is all that there will ever be. I think there will probably be a smattering of these things, and it depends on which partners you're looking with, right? Medicare is pushing us in this direction towards global risk, take more, have more skin in the game as providers, as payers. From our side as providers, we may say, there are some payer. I got a payer in my market who, even if I had the size, I don't trust their data, and I like the gain share. I like the position that I'm in gain share only, right? And so you just kind of play with these. We have 6 value-based care contracts at my organization, and they range across these. And like I said, one I don't trust their data. One we're not big enough to be in, right? One or two we have global risk with. That's not just with Medicare, right? And so I just wanted to kind of put that out there as when you think about contracting, everything's in play as options to consider, your individual unique situation. Paul?
We talked about different sizes of practice. We represent what we here at HCCI, we engage with people from across the country, varying sizes and so forth. You and Cameron, can you give us some advice like, I'm sorry, if I want to do global risk, what size do I need to be in? If I want to do a PMPM, what size should I be at least this size when I consider doing something in that particular bucket. Do you guys have any advice?
We might differ. Typically advise groups not to take any risk under 500 patients. That feels really low under 500 patients. I probably a little bit more than that. The problem with really small N sizes is you just don't, like, one bad outcome can swing the whole population, right? And so, 500, I don't feel comfortable in this primary care cap or this size. If you're working directly, you get a little bit more latitude sometimes with like individual payers or ACO. You can dig into their data more, right? Medicare tells you exactly they're telling you all the rules of the game. And Medicare generally has said, with the exception of high needs fee for service, about 5,000 patients is where you really get a traction contract with them. Now we're going to talk about other contracts, and they're trying to lower that to figure out how do we get a lower bar of entry, right? Because there are a lot of people that, you have to subset that, right? So you have to have a practice that's large enough to have 5,000 original Medicare patients to be in their programs. That's too high of a bar realistically going forward. So I think they're going to have to figure out how people inch their way there. But also there are like floors and ceilings, and we can talk about that in the contracting piece too. But to Cameron's point, you say, okay, well, I'm at risk for these patients. And you could set up with a program. I want a floor of I would never pay you back more than $1 million, no matter what the loss was, right? And then you could set, and then usually they say, well, then your ceiling is $1 million. You can't make more than $1 million, something like that. And so sometimes you can set guardrails if you want to try stuff, but trying stuff with new payers, exploring this stuff. Usually you start a little bit on the side closer to fee-for-service, and you kind of work your way there and build that relationship. These contracting relationships are long-term investments and partners. What do you think about the numbers? Am I close?
Amanda, I love it. And Paul, first of all, I just want to highlight for you all in the audience, you're getting a lot more than you bargained for on slide 3, right? You got Paul and Amanda and me bouncing back and forth, giving you numbers. ACO REACH high needs minimum to come in year one, performance year one was 250. So I wouldn't disagree that the 250 to 500, is probably a good number to think about as sort of the MVP, the minimum viable project. And I can tell you in PY1, we had 12.7% savings on about 270, 280, maybe almost 300 patients in performance year one. The beauty, and we'll go into this a little bit deeper, is to some extent, the sicker the patient population in a very, very bizarre way, the less you need to do make a dramatic difference, because just great coordinated medical care and counseling support for the patient and family and goals of care, et cetera, can have a profound impact, because they're usually fragmented and going all over the place and spending gobs with multiple complex chronic conditions. The second thing I want to highlight, because I think one of the things I'm supposed to be bringing to the faculty here, because Amanda and Paul are primary care WISMOs for both the business and clinical and operational perspectives, is kind of the palliative care and hospice slant on things, acknowledging that I've been sort of bridging both. And that is, and we didn't intend to focus on this, so I'm going to bookmark it, and if we have time and we're able to come back, this will be a really important point around the notion of attribution, and this notion of having accountability, responsible for the care. And this is a real challenge, I think, for two reasons for hospice and palliative care organizations. One is, if you take a community palliative practice, which many palliative programs are hospital focused and have a hard time figuring out their care and payment model in the community setting. But if you are doing or running or contemplating a community palliative care practice, very few have successfully been able to shift from a preferred provider, where you're a part of someone else's care model and someone else's total cost of care model, versus attribution, where you're the quarterback with responsibility for that patient and all the support and services that might include hospice and palliative care. And when a number of hospice and palliative care organizations tried to align into ACO REACH and get attribution, again, I'll jump into this in a little more detail in 5 or 6 minutes, almost everyone failed to get quote unquote alignment or attribution of the beneficiaries. So part of this is, and I just want to, again, highlight this from the hospice and palliative care perspective, the strategy really needs to be, are you going to do home-based primary care or not? Not you could potentially pivot your community palliative in that direction, but you've got to end up providing the preponderance of care and really going at it. And this is something that I'm just going to, again, highlight and we come back to later. Hospice and palliative medicine from the doc and NP and PA perspective has been taught generally as consultative model. In other words, you're an option and the primary or other consultant bring you into a case. And that option by definition means you're not accountable. And so this is a real challenge. You don't have the opportunity in the payment model scheme to, that doesn't mean you're not accountable, but in the payment model world, you're not accountable. And so this is a really, really, really pivotal moment, I think, for hospice and palliative medicine as value is starting to drive. And again, just last point on this, and again, we can come back at a little bit later. I've worked with a couple ACOs that have been talking to a number of hospice and palliative care organizations. And long and the short, I wanted to understand, so what's the opportunity, and this is 3 different ACO entities in particular in the past year. And I said, so if we come in wanting to go after total cost of care and be providing the preponderance of care in that particular environment, what are the opportunities? And there were all the ones that you talk about with upside potential for financials, quality, et cetera, and some downside risk, as Amanda emphasized. The interesting thing was, I said, if they are not quite comfortable yet, the hospice and palliative care program being the they, if they're not quite comfortable yet moving into that taking full responsibility or accountability and want to stay as a referral source within the network, is there any opportunity for shared savings or upside? And they said no. All 3 different ACOs said no. So I think this is a really important question for hospice and palliative care organizations to be thinking about. And I was, again, fortunate enough to be in an organization that decided they wanted to add a whole nother business line, which was home-based primary care. And that's how I got to meet HCCI back many years ago. I hope that's helpful. And that went off on just the numbers issue. But if you don't have the numbers that align or attribute that you can't be responsible for, you can be a great community palliative consultant, but you're not going to align into these value-based models. So this is I'm going to just touch on this. This is actually, to me, a super juicy slide, which is we are all halfway there, right? I forget who's that sings that song. We're halfway there. Everybody's stuck in what I call the X, which is we've got some fee for service, which everybody, particularly Medicare, wants to get rid of. And we've got these value-based opportunities, which everybody's trying to move towards. At the end of the day, and we'll talk a little bit more about this when we look at some of the models later on, case management and care coordination, complex care management, CCM is a language you'll see in fee for service in the Medicare billing manual. The most successful high needs ACO reach, again, we're bouncing around a little bit here, had an intensive case management epicenter with provider oversight. Very, very different from the typical fee for service model of physician and NP billing in the home setting. And either investing in expensive non-billable infrastructure previously or not, and drowning the providers in the fee for service model. So what we've been doing a lot of work around is saying CCM, chronic care management, or PCM, more discussion on this later, is the key in fee for service to doing the intensive and getting paid for the intensive case management and care coordination for folks with multiple complex chronic conditions in the fee for service world. And again, HCCI has some great teaching and training and resources on CCM billing and coding, et cetera. They have taught me that probably at least 51% of what I know about this. And what that does is set you up in your halfway there model in fee for service, do the provider oversight with intensive CCM with the clinical staff under a QHP, qualified healthcare professional, doc, NP, PA, CRNA, typically not in home-based practice, but doc, NP, PA, with the nurse, social worker, medical assistant, LPN, that can do this intensive, high-value case management care coordination, and now, since 2015, get paid for it through CCM. That builds your care management infrastructure in fee-for-service land that immediately pivots over to a high quality, high value PMPM model, again, with provider oversight. I worked with a colleague a number of years ago, last point on this, and then we can jump into the models, who was a home-based geriatrician who said that he was the captain of the ship. And I always struggled with that because I come out of the hospice team-based model. And as I kept thinking about it, if we go at the old fee-for-service model, the physician could entirely be the captain of the ship because they're the only reimbursable component of the care team. Again, NPs and PAs being also possible. We do have to, I think, have a complete paradigm shift to have the care being driven on an hourly basis by the case management team and have the provider be a critical oversight, communicating, collaborative partner. Interestingly enough, that model is how the typical hospice team operates, with intensive home-based care provided by an interdisciplinary team and a medical director providing oversight and home-based consultation. I'll just pause on that and we'll continue forward. Amanda, anything you wanted to I'm trying to look at you in the near the podium and see if you're waving hands because you want to jump in with a point here.
No, but now that I know you can see me, I'll start waving my hands.
Okay, good.
So good. And
What
you
do you
guys
got?
jump in with questions too. Okay.
So long and the short is we're going to focus, and I think this is going to be super fun because we're going to spend a little bit of time now, I think, on some of the Medicare models. But Amanda can absolutely tear off on the commercial opportunities with MA and beyond. But just a couple of fundamental rudimentary things. CMS, Center for Medicare and Medicaid Services, run by the federal government, comes out of your FICA trust fund that's supposed to go bankrupt every 10 years. I hear a 3 to 5 year plan for it to be bankrupt, and 10 years later it's not bankrupt yet, but it's supposed to be soon. And that's in part because the meter's running. Expenses are out of control relative to premiums. And so they've really leaned into value-based care programs. VBC programs. They can either do that by law, they can say, here's the new model, or they can do it through the Center for Medicare and Medicaid Innovation as demos or demonstration projects. And I think the demos and the legislation, if I were to, are important, and we'll talk about this if we have time. They've looked very recently, actually, at some of the MSSP data. At least that's what I've seen attributed to the quote that's here as your fourth bullet on this slide. And again, Amanda's going to talk with you more about the Medicare Shared Savings Program, MSSP, after I tell you a little bit about ACO REACH. Whether it's an MA or an ACO, again, I sort of think I'm a lumper, and you can lump a couple different ways. What CMS has seen is, particularly if it's physician-led, or clinically oriented, operated, you have the highest likelihood of doing a really great job from a high value perspective, driving quality and reducing costs. There's stats on that to the tune of 60-some% of all ACOs and run by physician-led organizations have shown significant financial savings and been a big driver of billions of dollars in savings. So what they've said, and I think this is one of the most important things for all of you thinking about this pivot, this transition from fee-for-service over to value-based care and payment models, is by 2030, which when they announced this, I think it was about a year ago, we're down to about, 5.5 years between now and 2030. They want every OM, original Medicare beneficiary, to be in an accountable relationship. An accountable care, an accountable relationship. That generally means that what we're talking about tonight are the models that they want people in, because this meter running fee for service is neither quality nor cost effective often enough. So that's kind of the Uber framework that we're then going to drill through. And what I want you again to stay focused on, while we'll run off on a couple of details perhaps, is what's the big picture? What do you divine in terms of truths, which again, we'll try to highlight as we go through. So these are a bunch of different models. I'm going to just touch very, very briefly on GUIDE, and we're going to come back to that later. And then I'm going to talk a little bit more detail about ACO REACH. And then Amanda will pick up and talk about the Medicare Shared Savings Program next. But there's a bunch of models. In fact, I'll just highlight that one of the oldest, if you want to study a model that's been in place for 20 years that has amazing components of outcomes to it, you can look at the Program for All Inclusive Care of the Elderly, which we're not focusing on here tonight, but PACE. which has been around for decades, and if done right and well, is a really nice way to care for frail elderly and keep them in the community rather. Yes, please, Amanda.
And I was going to add, primary care first is closed. They've kind of pivoted that a little bit to making care primary, which is not in Illinois, so we're not going to talk about those tonight. But CMMI has a great website. I know Medicare with a great website, go figure. But they have a great website, and you can go in and you can search by your state and see all the demonstration projects that are offered in your state. And so I encourage you to do that. But we are going to go into the other three, but I wanted to just touch on these two. This one is no longer being offered, but it laid some important groundwork. And this one is not yet in Illinois. It just launched in 8 states this year. So brand new information coming out of CMMI.
All right, and so if you're going with brand new information, I think it was Tuesday, the hospice component of the value-based insurance design model was also closed and will wind up at the end of this year. So this is part of this is innovation is alive. There are new models coming out. There are adaptations to models, which we'll touch on, and there are also models that they are no longer running. So really simply here, this is really an interesting thing, which I love to highlight because this transition, the direct contracting entity, GPDC, was transitioned, and this is a linguistic slide we don't need to spend too much time on except to highlight. This is interesting politics, honestly, and the Biden administration is a really, really strong advocate for underserved and social determinants of health. And so they took the direct contracting model, which was brought forward in CMMI in the previous administration, and really said, we want to retool this with largely two primary issues. One is much more of a focus on health equity and social determinants and underserved communities, and it has to be a component of the plan. That's what the REACH acronym. Otherwise, the payment model is really largely the same. They also wanted to make sure that there was more transparency in the ownership of the of these ACOs, so that they were intended to be predominantly, and I think there's a slide coming up here in a second, 70%, if I remember correctly, provider-led, and the financing has to be through provider-led entities, not PE, private equity, or venture capital. So long and the short is on the next slide, please, Amanda.
Oh, I
this
was
is an
just
ACO.
going to add.
Go ahead, please. Oh, I didn't see you waving.
Nope, I wasn't going to do it every time. I mean, it's good to get some exercise, I guess. But under last 3 administrations, we see them fiddling with this, but we don't see this changing as they head towards value-based care. So as we go into the election time, lots of things could change. For us, or taxes, all sorts of things, but we don't actually see CMMI adjusting, heading towards value-based care, heading towards quality improvement, lowering cost. The details in it, they might take offline for a period of time, bring back on like they did with REACH, but I would expect this to stay regardless of administration.
So there are, bottom line is this is an ACO model, just to be clear, accountable care organization. And again, the issue of aligning the fee-for-service beneficiaries into the entity, and we're not going to go into detail on this at the moment, but that gets back to attribution. In other words, you can't be accountable unless you're taking full responsibility for the care and the payment. There are actually 4, but for the sake of this, 3 models. There's a standard ACO. The way I like to think about this, and new entrants, those are variants on 85% of Medicare. So the Medicare beneficiaries, let's just kind of think about it that way, to be lumpers rather than splitters. And the bottom line is it's for the large population of folks that aren't that necessarily that sick, not necessarily that complex. They may be doing well with a little bit of diabetes attention, for example. The population that I think is, now you can do a home-based medical practice off of some of those. The population that I've been focused on has been really the 15% of beneficiaries that have multiple complex chronic conditions. And there's definitions of that, which again, we can talk about later, that it puts you into the category in CMMI's world of thinking about high needs. It's really the people, generally speaking, who've been hospitalized a number of times. They are people who might be similar to those that you're trying to keep out of a nursing home and in the community in a PACE model. And they're really the population that, if I were to kind of crudely say, are in the last couple of years of life, which is tough because it's not a prognostic model, but they're moving in the direction of more and more complex chronic conditions, more complexity of care, and it's that costliest 15% or most complex 15%. Really, the key component to this is that this needs to be the ACO REACH component needs to have an implementation of a development of a plan and the implementation of a health equity plan. And there actually are specific tools that are resourced and referenced that you can leverage. Really the expectation is, and they monitor, that you are addressing social determinants of health, SDOH, and specifically targeting in some way, shape, or form that you're serving all people, including those who are less likely to be well served. And there are actually some, just by the way, some really great websites, 2 or 3, that really correlate zip code with health risk and complexity of medical conditions and risk of death from those conditions, and are generally underserved populations. And they're really, really helpful, that Confer Analytics may end up talking about a little bit later. This is the point I referenced earlier. This is a specification of ACO REACH. Participating providers must hold 75% of the governance structure. This is really intended to have this be driven by providers for the benefit of the beneficiaries, and reduce the likelihood that this is just run as a money-making entity. There's a bunch of BEs, as they call them, benefit enhancements. There's one of the benefit enhancements is around the NP scope of practice, which we can touch on if there's questions on that later. What I'm going to say here, so I'm going to go super zen up here for a second, because you can get lost in all the details. At the end of the day, I'm going to suggest you can measure all sorts of different things. At the end of the day, your goal is more days at home, fewer days in the hospital, and they're effectively inversely correlated. More days at home, fewer days in the hospital. And that's really what these claims-based measures are looking at. There's patient experience measures, obviously, through CAHPS. There's opportunities, which we'll talk about a little bit later, for referring partner and healthcare partner satisfaction, and a number of other things. But at the end of the day, and I actually had one Medicaid plan that I was working with, that basically we listed 5 or 6 different quality measures that we thought were really important as providers. And all they wanted to do was look at hospitalization rate and reducing the spend on hospitalization rates. And so really it's up to us, I think, to engineer the care model that takes great care of patients in the community setting. And ultimately, I call it the Velcro care plan that helps them to stay safe and comfortable at home and out of the hospital. And whatever you do that does that, and we can talk about those elements and aspects later on tonight. But at the end of the day, what the payer, remember, they're all generally running businesses to make money, and hopefully take good care of the beneficiary. But what they really want you to do is whatever it is that you magically do, you providers, us providers in the home setting, that ultimately keeps them at home more and less in the hospital. I was just going to finish, if I could, just one thing that I want to just highlight that we didn't in these slides is, real quickly, because we're going to come back to this later tonight. The payment model is one of the first that actually addresses some of the issues that were in Independence at Home, which is another model, for example, and others, and Amanda, you may touch on this, which is, hey, CMMI, you want us to do a better job, but unless we share savings at the end and get money 2 years later when we true everything up, how are we supposed to fund this now?
Yeah.
This maybe being your complex case management, set of infrastructure and resources, et cetera. And so what they did was they basically say the average beneficiary, your benchmark, typically has a spend of, and it varies by where you are, but just use for a round number because this is within hundreds of dollars, $3,000. And they say, out of that $3,000 benchmark, we're going to advance you a PCC, a primary care capitation, of 7%, which generally, depending on your market and your population, let's just say for simple numbers, is $250. And effectively what they're doing is prepaying you per beneficiary per month, that PMPM, $250, so that you can actually start your case management care coordination right off the bat with your ACO REACH model. Now, if you lose money at the end of the year, you have losses plus you have to pay that back. But it's a trend I wanted to just highlight before we move forward, which is they're prepaying for one of the first times that I've seen, at least, for that opportunity to provide case management and care coordination upfront. I just wanted to highlight that, Amanda, and then off to the races with you.
Quick on the quality piece. So one of the things we talked about, I think you guys asked about kind of a measure. Why do we the measure to track is days at home, as Cameron's saying, and days in the hospital. Why do we care about lowering days in the hospital? Why do we care? It's expensive. That's right. If it was $5, we wouldn't care at all. It is super expensive. We actually don't care if we give you the wrong medication or if we do anything else, as long as you don't end up in the hospital. If you die on the floor, you're super cheap. That's a great deal for us, right? And so that hospitalization, that rehospitalization is where that money is coming from. That is your low-hanging fruit of the metrics you're using to show value. And if you're in a value-based care contract, how you prove yourself out is you lower that number. That's how you make money by improving that major quality measure. They're all, when Paul and I talk about quality, we're going to talk about a lot of them, but that's how this ties to money, money, money. Medicare Assured Savings, yeah. Oh, he's waving? No. Oh, I'm sorry, hi.
I just had a question.
Yeah?
I forgot. So when we talk about lowering days of hospitalization, how do you or how does your organization measure that? Because when we look at it, we're maybe looking at it, months before they're in the program or months after they're in the program. Is that the standard or?
Yeah, that is comparable. You can, when you're in these programs, Medicare gives you data too. They give you a data dump, and so you can kind of look at that of your hospitalization. You could take your aggregate hospitalization. So I have 1,000 patients. What's my rate of hospitalization? I put an intervention in place. I started calling people, 2 days after discharge of the hospital, and I reduced rehospitalization by this much. And so, yeah, that tracking of whatever you can find as your data set, correct?
Okay.
Yeah, that's what I'd use.
Thank you.
Yeah, and the nice part is Medicare does give you data. It's pretty tough to cut individually. You kind of need some support on cutting it when you get all this stuff from Medicare, but if you get in one of these programs, they do at least give you the data. There is a lag in that data, but that is the thing you're trying to reduce. And so the real-time data comes through ADT transfers, the ADT data. And so you get that ADT feed, admission, discharge, transfers, and you say, oh, someone's in the hospital, I need to make an intervention. So they don't go back to the hospital. So readmissions is kind of your lowest hanging fruit, and then your hospitalizations is how do I avoid them from the hospital, right? Getting the pulse in place, getting the, all the right supports in place, having the caregiver conversations, getting them on the right medications, removing the old medications. That's stuff to prevent the hospitalization. That's a little bit harder to prove, right? Because it's preventing something that hasn't happened yet. But with Medicare, with any of these programs, they kind of say, here was your population, here's how you were doing, and now here's how you're doing, 18 months after the fact, which isn't great data, but it's something. Oh, sorry, I skipped over by MSSP. Medicare Assured Savings Program. So I am not a fan of ACO REACH. I am a fan of MSSP. I like it because it's what we distinguished early on is what's part of legislation and what comes through CMMI. I like it because it's part of legislation, so they can make tiny tweaks to this, but generally, it takes an act of Congress to work together to change it, which I don't think will ever happen. So I like the program a lot. It's a similar kind of idea. 5,000 patients to get in, let's see. 5,000, it's an ACO, Accountable Care Organization, original Medicare patients. You need 5,000 patients to be in the program, and then you start kind of tracking your data. It's pretty hard to get to those numbers in our population. It's hard sometimes to even get to the numbers of ACO REACH. One of the ways we as smaller groups do that is through conveners. And some of them are for-profit, some of them are more non-profit, but conveners that have kind of come together and aggregate our population. So we say, okay, 10 home-based primary care groups have come together, we file together, and then we figure out how to split out those money. I think that is going to be on the rise. I think the convener work is on the rise to get to these. When we talked about the earlier models, they do test stuff in CMMI. That making care primary, to Cameron's point, is a good example of a model where they're trying to pay you in advance a little bit of money, and then you have a little bit of, you move on a track system towards kind of more risk and more accountability, but you need lower volumes to get into those. And so we're heading that way, but there aren't the big proven systems yet. Really the longest running system is the MSSP. That's the one, typically when you see Medicare release data, that's the one that's been around since the Affordable Care Act. So that's the one they're releasing data on savings for. So, but they're all heading the same direction. They're all testing these ideas of how to get people into the program. The nice part is Medicare generally wants to give you money, right? Medicare wants to figure out how to get money into the pocket of people who are doing the right care, keeping people out of the hospital. So, like, they're getting there. They're getting better. Any questions on MSSP? It's a pretty big population, so we don't go into great detail about it because you need 5,000. Okay, so Medicare has 4 parts, A, B, C, and D. C is often called Medicare Advantage. We're very familiar with Medicare Advantage. Medicare Advantage is an add-on that you can pay, or sometimes now $0 premiums pay, and aggregate your Part A, B, sometimes D services into one card. It's usually locally purchased, right? So we have Medicare Advantage, the 20 options in Illinois, and everybody gets all those flyers for that. You can contract on Medicare Advantage. There's just a slimmer margin here, right? This is an entire population. We're not subsetting, right? So this includes quite a few healthy golfers. People give away a little less. So how do you contract on Medicare Advantage? Typically, you do a trended MLR. So you go to Blue Cross, you go to Humana, and you say, give me my MLR, my medical loss ratio for the last 3 years. Here's how much you spent. And you say, if I could beat that by 1 point, will you give me that savings? If I could beat that by 2 points, will you give me that savings? So those are some ways to kind of get into, with our population's Medicare Advantage. But that is Part C. And so you can subset your data, I always recommend everybody look at their data and say, what payer source does everybody have? How many original Medicare? How many MA? Our organization, for example, has 1,000 MA patients, which is great, except it's split among 7 payers. That's a lot to contract with, so we really only contract with the bigger ones. Questions on Medicare Advantage? Another offering under Medicare that's not, it's technically through legislation, but it's very, very old legislation. So underneath Medicare Advantage is the SNP plans, so the special needs plans. Those are Part C. The federal government takes a look at the populations that I'm about to outline and they say, hey, we need some extra coordinated care services with this group. There are three SNP plans, so institutional SNP plans, so you live in a facility, a nursing home, or you're eligible to live in one. Sometimes you hear IE, institutional eligible SNP, or institutional SNP. So these are more nursing home focused, maybe assisted living. Dual eligible, this one is a growing population. So this one, actually, Melissa sent me a link tonight of all the work that Illinois has put into funding a lot of DSNP programs. This one I would absolutely take a look at. How many dual patients do you have? Who's aggregating that, right? Who's the payer that's coordinating that together? That's a huge opportunity. That's a growing population. We're not getting cheaper on anything, on assisted living, nursing home, any of those expensive. So care's not getting cheaper, so we're running out of money faster. So people are getting on Medicaid faster. One thing I will say about this is there are 2 types of patients that are Medicare dual eligible. There are the patients who have had money. They're 65, they're older than 65, and they run out of money, right? And now they're on Medicaid. So they have Medicare, and now they're on Medicaid. And then you have the patients who have been on chronic Medicaid, chronic, poverty, chronic illness, chronic under supported members of our community who age into Medicare. Those are really 2 different populations. So I think about your care model interventions as looking at those as different populations. We're learning a lot of valuable lessons that those are different groups, right? You just spend down because you're spending a ton of money on nursing home care. That's a different life experience, has a different support system. Those are probably different chronic conditions than if you've been on Medicaid your entire life and aged into Medicare. And then the final one is chronic conditions. So the CSNPs, this is Medicare saying, hey, let's take a diagnosis, let's take a dementia, let's take HIV/AIDS, and let's just aggregate that. So you need a pretty big, Chicago's a perfect example, New York, you need a place where you can get a lot of patients. So the health plan doesn't necessarily have to be big as long as you can get a lot of patients in that plan. And so those are opportunities too. If you have a great diabetes program or something like that, and your Blue Cross of Illinois is I'm picking on them a lot tonight, I guess. Blue Cross of Illinois is offering a CSNP and diabetes care, and you can make that intervention. You can go make money on that. So I always say, when you improve care, someone is making money. You just need it to be you.
I'm not going to go read every objective here. You can read it on your own. And for the sake of time, we're going to move on. And I think at your station where you're sitting at, there is a case study. Now, Cameron and Amanda, they've talked a lot about numbers, models, and cost, and attribution, and all that. But at the end of the day, we're talking about people. We're talking about patients. We're talking about delivering the care that's consistent with their goals, right? So take a look at Minerva. I just want you, when we used this case in the past in a different setting, we actually had people get around and talk about the case and go over what you would do with Minerva. We've all seen patients like Minerva who's older, who's got dementia, that you're seeing at home now because she's coming back from the hospital yet again with heart failure exacerbation. She's got dementia. She's got CKD. And then she's got a pressure wound. All right. These are the kind of patients that we need to take care of. Cameron and Amanda said, the quality, it is about keeping these patients out of high-cost centers. And that's not necessarily a bad thing because many of these patients want to be home. They don't want to go to the hospital. And, I work for a health system. I work for hospitals. And we've all seen what happens to them when they go to the hospital. We try our best, but what happens to our dementia? Right? I see heads nodding. Yes. They get sedated. They get extra medications, and they come home even worse. So when we say, we want to keep people out, sometimes it can carry this negative connotation, like you just want to save money and deny Minerva the care that she needs. I think us as clinicians and as educators, we need to show them that no, we're bringing them great care, better care, at a place where Minerva wants to be. A majority of our patients want to be treated, and that is at home. Okay, so real quick, she's got HFrEF, she's got Alzheimer's, she's combative, she's had a stroke, she's got CAD, CKD, arthritis, hypothyroidism, and recurrent UTIs. And you can read through the case here and take a look at her medications. All right, and when we teach residents, I try to help them put a framework around how to manage really these complex patients. Many of the residents come, when they rotate with me, they say, it's really difficult for us to put our mind and our care plan around somebody like Minerva. They're so complex, all right? So one of the section, it talks about the 4 M's plus the multi-complexity M, so it makes it the 5M. So for the sake of time, the first M is what matters most. What their goals are will drive what your care plan is. Okay, Minerva could be somebody who might be pivoting towards a palliative hospice pathway, or Minerva could be a family want her to have a better quality of life, stop these UTIs, stop the CHF, right? We want to keep mom out of this cycle, not necessarily get her onto the hospice path, all right? So if you have a lot of Minervas that's attributed to you, and they don't necessarily want go into the hospice path, how are you going to manage them? So what matters most? Mentation. We talked about what are you going to do to treat their, if there's underlying illness, how do you screen for that? How do you treat? How do you get resources? How do you manage her dementia, right? Mobility, we got a pressure sore, she's at risk of fall, she's got falls, she's got dementia as well. And traumatic injury is still a common reason for our patients to end up in the emergency room, which we don't want them to go, and they don't want to be there, okay? Medication, that's where, Cameron said about a physician oversight and leadership and education as clinicians, as expert clinicians in managing she's got HFrEF. I think her EF is 35%. Do you know the 4 pillars of medications according to the latest guideline in managing HFrEF? That as clinician, you should be well-versed, very comfortable dealing with, you got an ARNI, that's your Entresto. You got your MRAs, that's your spironolactone or eplerenone. Now you got your SGLT2s, that would be Jardiance or Farxiga, and your heart failure beta blockers, metoprolol, the succinate, not the tartrate, carvedilol, and bisoprolol. All right. So as clinicians, you need to know, yes, we're talking about attribution, keeping them out of the hospital, but one of the things you need to be good at is to know your stuff, because Minerva needs your intellect and your sharpness to give her the best care possible. And the last is this multi-complexity. I think the point I want to make is, who is going to be on your team to manage the 4 M's, 5 M's? All right, will you have a pharmacist, social worker, wound care specialist? Are you going to have a care coordinator to oversee all of this so that you can deliver the care? When you get that care management fee forwarded to you, think about who's going to be the best person on my team to help manage somebody like Minerva. So I already went through most of this. And under fee-for-service, we all know it's a struggle to get that paid for, right? That's why we are looking forward to value-based care. Amanda. Oh, any questions?
I got one. Am I on? What's Minerva's last name? Come on. Nobody is a Harry Potter fan? Get out of town. Get out of town. I want to go back. So the only reason we put this slide in too is I am not a physician, right? I'm a CEO. I like negotiations and contracting. This is kind of what I hear. Community dwelling, long list of hospitalizations, probably a lot of long list of diagnoses, medication, a lot of hospitalizations, treatment, high utilizer, frequent flyer. This is what we call these folks, right? In the example, we make them dual eligible, and we say, you're going to do the same thing clinically. Your clinical teams are doing the same thing no matter what, right? Regardless of the payer, they don't care. They don't think that way. You can either get paid, fee for service, or maybe care management fee or whatever, or you can start thinking about when you do the right thing, someone's making more money on that patient. And how do you think about getting paid under value-based care contract? So we've talked about some of these things. I'm not going to go necessarily through everything. This capitated PMPM as a way to inch your way towards things, right? The place I always start is look at your payer sources. What is your population? Where are they? Who are the sources? Are they MA? Are they DSNP? Are they in a special program that's part of a hospital, right? Are they in a heart failure program? What is the programs and the payer sources that you're already getting, and how do you kind of add to that? Again, possible fee-for-service, for the billable visits. You could maybe do a risk shared savings model for your pool of patients. You could talk about being in an ACO. You could talk about quality bonuses. You could start talking about these things because you're doing this. The other reason we always highlight Minerva, and I like Minerva because she has a name I remember because I'm a big Harry Potter fan. So you got to de-identify your name when you have a patient story. But when you go to a payer, you bring your patient story with a name they can remember. And it's a fake name, obviously, but it's a name that they can remember. And you say, Minerva McGonagall has these things going on. And then they always kind of remember that. And so you open with the patient story. And you ground them in why you're doing this work. And then you start asking for money. You say, this is the work we're doing. These are what we can prove. This is the value we can bring. This is the hospitalizations we've reduced. These are the days at home. You don't have to track everything, but you start thinking about that foundation of what you can kind of prove out. Now, at the bottom, we put this little box, make sure you're ready for it. This clinical model is the foundation. So as Paul and Cameron, as physicians especially, they're talking about the clinical model. That's the foundation of what you're doing. Is your clinical model ready? Have you talked with your providers? Are they ready to pivot into value? Do they really understand value-based care? What are your strengths and weaknesses? I'll tell you, one of our weaknesses for a long time was technology. We have been tech laggards forever. We spent a lot of time on the clinical model, and we have been completely outpaced by technology. So patient portal, we don't have it. EHR got it in 2019. Data, just an Excel file. We don't know what to do with it. So, how do you take all that information and you understand that was again a weakness. Strength, clinical education, filling out pulse, advanced care planning. So we had the basic foundation from this clinical model, but we didn't have the support on every side of it, right? And so what do you need and who do you need to onboard to make sure you're ready? I'm going to tell you one of the biggest problems sometimes with either health systems or groups, their CFO. They don't understand how this works, right? So it's not, you can get a doctor to buy into, okay, let's reduce, hospitalizations. I think Paul would say, yeah, I want to send fewer people to the hospital. I want to do better care. Can you get your CFO to understand that you're going to get paid 18 months later under a Medicare contract? No, that's super complicated. That's really hard. Who do you need on board? What kind of education do you need to understand before you jump into it? You're coming up, say something.
1 minute comment is, Amanda talked about having a story to tell, and I remind my providers this, and whenever I have a chance of talking about home-based care, never underestimate, and you guys have heard this, never underestimate the power of your presence. Being there with the patient, all right? Getting to understand your social determinants that drives 80-90% of medical conditions, right? Being there, being a good listener, spending time with them, having eye contact with them. 3 things I tell them what our patients need from us. They need our minds, they need our eyes. That means not on the laptop, okay? Eyes also means your presence, all right? And they need our time. The 3 things that'll differentiate me from ChatGPT. We already know from studies, ChatGPT gives better answers, more comprehensive answers, more compassionate answers. Wow. All right? How am I going to do better for somebody as sick as Minerva? Okay.
So let me, wait, don't go away. So let me play that off on the contracting side. So I'm a contractor. Paul has this passion. He's telling me this story, and I have to go get someone to pay for it, right? So he says this story to me. So how many patients do you see in a day, Paul?
8 to 10.
Okay, so I go in and I say, our providers see 8 to 10 patients a day. And these are the infrastructures, right? We have an MA that's going to ride with him. We have a care coordination that's going to support him. These are our metrics that are supporting him. Because the number one thing that he wants is eyes on a patient and time with a patient so he can do this work, right? Boom. Bada bing, bada bing, right? Like you've sold the story. You tell the story, this is our patient. You say why the providers are mission driven, where their passion is. You say how you support them. You show them the data. And you say, we want to be a partner with you, right? I want to, here, next slide. The value proposition. Think about your strengths and weaknesses, your larger healthcare system, your partnership, who is going to partner with you, and what are they getting out of the deal? One of the biggest things is, so the ACO REACH came out, right? And we're talking about high needs, but I'm going to just say something. Anybody who's doing facility care, you might do a little bit of transitional care. If you're doing a little bit of transitional care too, I know it's not outside of the home visit realm, but just put the hat on. Do a little bit of that. You're now seeing ACO REACH patients from these big health systems there, and you're now taking care of them with all your value-based care, geriatric focus principles. You can make money on that. Go and say, hey, I'm seeing your ACO patients in my TCU. I'm redirecting to our assisted living. I'm capturing them there. I'm sending them home. I'm recapturing them home in our home visit program, and they're your patients in your ACO. Pay me for that, right? Help me figure out that. So this is the leverage, the value proposition, is figure out who's getting paid today or who's not, and how you position yourself. And then finally, what data do you get from your partner, right? How do you formalize that? In my actual contracts, I'll say I want a dedicated account rep. We're going to meet quarterly. You're going to bring this data. I'm going to bring this data. And you build in, well, what if it doesn't work well? Okay, well, then we're going to do these things, right? We're going to revisit the contract. We're going to change the contract. The floor ceilings are open.
I think Cameron's waving.
Okay, go. Sorry.
That was actually 2 thumbs up. That was my Siskel and Ebert.
Oh, okay, good. Building the relationship with the payers and the potential partners, right? We talked about having the champion to lead the discussions. I bring the clinical team, but I don't bring them at all meetings, right? I can do a lot of these meetings. If I'm in a room with a CMO, if I'm in the room for the medical director, I get a clinical partner there because they're talking the same language. So think about your champion and what that story is you're telling. What are the goals and how do you talk about those things? I always recommend, if you're going to pitch to any partner, again, an ACO, a convener, a Medicare Advantage plan, is look at their website and understand what their value sets are. I have 2 payers that I work with. I have one global and one significant risk, and one of them throws all over their website patient-centeredness. The other one is just kind of more of a traditional health plan, but patient-centeredness. So always open up with the number one thing that's important to you and to me is the patient, and we care about the patient first, right? And so you put that in, their values are your values. And then maintain that relationship. Think about a scorecard for your practice. How are you doing? Reporting back to them. They love to see that you get no technology. They love to see how you're doing. They love to see that's working. One of the things I did in the pandemic with one of our partners is I called them up every month and I said, this is how many masks we've delivered. This is how many vaccines we've done. This is how many blah, 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 blah. And so at the end of the year, the payers had so much money, this is a true story, they just gave us some. They called me up and they said, you did such great work during the pandemic. They have a certain amount they can't keep legally, right? And they said, we have extra money and we're going to give you money. And for 2 extra years, they gave us money because I kept telling that story and putting it in front of them. That's maintaining the relationship over time, right? And consider tracking your sickest patients, days at home, days in the hospital. This is easier with technology than it used to be. But that equals financial savings. So even a point, 2 points, 10 points, that is money in their pocket and your pocket. If you don't have that data, the nice thing about HCCI is they have a repository of data and practices that have put all this information in, and they can help you figure out how to extrapolate data. So if you have one metric, I reduced hospitalizations, improved days at home, I did this, they can bring a study to say, okay, that equals this amount of money, and then you just say, I pulled that from here and I applied it, and this is the kind of savings you're gonna get with my program. And even, ma'am, I don't remember your name, but even you who's starting a new program, right? You pitch to someone and say, I need a little seed money to start this program because this is what I'm about, and if I could do this, this is the kind of savings you're going to see with me. Would you send me your top 5% sickest patient in this geographical area, right? Like, why wouldn't they pay for that? What are they going to say? No, fine, whatever, you didn't need them anyway. Okay, key takeaways, bada bing, bada boom, you saw it. Anything else? Quality? Questions? Contracting is my favorite. Negotiations are my favorite. No means yes. Let's start there. Only in negotiations, okay? I'm on camera, so only in negotiations it means. Let's go again. All right. Value proposition. 15 minutes, we got this, Cameron. I can't remember.
Wow.
Is it you or me?
All right.
It's you.
You roll. You are on fire.
I love it. I love this stuff. I love it. Especially this is like
Because
my,
it starts
bread
off
and
with
butter.
negotiating contracts. You go.
Okay. All right, key quality metrics. I am not a MIPS expert. HCCI has MIPS experts, so you can work with those guys. But as you sign up with these programs, especially the national ones, you need to do certain quality components. And they're really kind of 2 quality components. We kind of only go into MIPS a little bit here, but to think about. And one is MIPS and one is kind of STARS, and that's for the health plans of how they get money and what they're measured against. And so again, that's in your research of what's important to them is their HEDIS measure, their STAR measures, and then the MIPS that you have to do and you're required to do. And so again, I'm not a MIPS expert, but I would throw up just a few meaningful metrics to consider, to track. And so what I would say too is the business development guys here is you don't have to necessarily track these. A lot of these early on, we did on paper. We took one provider and we had it was an LPN for us, but your LPN, your MA, and we just said track for 2 months. How many calls you took that you didn't send to the hospital, or how many days at home someone had, or how many calls you got on this and you diverted. And we just wrote those down, and we would do a couple of those time studies, and then we extrapolated the practice and said, okay, in a 6-month stretch, we were able to do this many, and we can extrapolate to this for our entire practice. And so I like to say, this is not you don't have to do all these things, but start thinking about your quality measures and start thinking about what this looks like and what you can track and what you can prove. And you just need a couple of them. But remember, you are trying to prove something is important to them. You're trying to save them money or make them more money, right? What are you doing with STARS? STARS is making them more money, which you can eventually share in is the hope, right? And so, and your improvement here on the MIPS is saving money for the system. So questions on these?
And Amanda, the only thing.
Oh yeah, you go.
Oh, the only thing I would score one of your points like five lines underneath it, which is pick 2 or 3 or 4 that you think you can nail most readily. I think the worst is to either overpromise and underdeliver with a list of 100 or 20, and really think about what you can deliver on. And then the only things that I would add, you referenced this earlier, Amanda, and we don't call it out explicitly on this slide, but when you look at, so it's advanced care planning, goals of care discussion, is just a critically important process measure. And there's again, a lot more that can be talked about there, but I wanted to anchor it back in, for example, again, where are people going? CMMI's VBID model has had four domains: palliative care and goals of care. They lump the two, but there you go, palliative care and goals of care for hospice. 2 is enrollee experience, and they lump that. So that's the patient experience, which gets at some of the things that we've already talked about, as well as care coordination, and then hospice utilization, quality, et cetera. And you should be able, if you're a hospice organization, to have those. And then the last is implementation of a health equity plan. And I would really encourage you all to think about some way of integrating community health workers into your care model, and using there are a couple different validated social determinant screens, and really understanding, as Dr. Chang said earlier, sometimes 80 to 90% of the complications and issues and whatnot can be explained by social determinants. And so if you're tending to food insecurity or the inability to get to the pharmacy to get their medicines from a transportation issue or safe housing, et cetera, I mean, these are things that are critically important to making sure that we're addressing. So I just thought it would be helpful to mention those.
And sir, I don't think we exactly addressed your obstacles to providing care in the home, but I would say this falls into that, is vision and operations creep instead of focus. Keep that strong focus of who you are, what you can prove in these numbers and in your operations, right? Spreading yourself too thin can be detrimental to the whole. Which is like
And the only
one sentence of your question.
Yeah, no, the only thing, Amanda, that I would add is I had the privilege of working with a hospice medical director whose primary job was with a practice that was involved in 5 different contracting arrangements. And one of the questions for value-based care in their primary care practice, and one of the questions that came up that I think is often very, very important is to say, oh, there's this list of 105 different contracts. There must be a whole bunch of different measures. And I actually cross-checked this with him. I said, was it really pretty much the same 4 to 5 measures with 1 or 2 minor variations? And he said, yes. And I just took that and I wanted to share that with you all, that don't overcomplicate it. There really are some handful or so, and we're going to talk about 4 categories of them here, that you can really capture and are meaningful. Don't try to kiss every need, because you'll just chase your tail forever.
Yeah, I think that's really good. I think this kind of covers the ones that we've talked about. The one I would just say as just a little asterisk here is the polypharmacy reduction. This is a lot of the STAR measures is deprescribing. I think that's a pretty flawed measure on Medicare's part, but it's kind of the best we can do at this time. But some of our measures are the deprescribing statins, deprescribing, prescribing diabetes stuff. Like this is one of the trickier ones. I've always been fascinated, and I don't know Cameron or anybody else in the room, or Paul, if anybody knows. I think it would be really cool if EHRs tracked how many medications you came in on and did a 30-day or a 60-day or a 6-month review and said, how many do you have after that? So I think that's kind of tricky to track, but I don't know any software that's doing that today. But the deprescribing is really Medicare by and large. Do you know?
Yeah, and I don't know of an EMR that does it. Yeah. We manually captured it, but this is an opportunity to highlight, I think, as well, one point that I wanted to raise. If you look at the 9 domains of the GUIDE model, which is a dementia care model that was just released this past year, one of the 9, similarly, Amanda, is medication management and reconciliation. Yeah. And so I just think, this is a theme that CMS is very keenly focused on. Particularly polypharmacy in the elderly, both from a cost, but also from a morbidity and mortality perspective. So just wanted to underscore that. I think there might have been a question.
Get the man a piece.
Just real quick about Confer. Melissa talked a little bit about analytics. I won't go into details, but the one thing I want to tell you all about Confer as relates to the other analytics that are out there, it is home-based oriented. And that, I think, distinguishes from all the other analytics software that's out there. We'll be happy to talk to you more about Confer, either in person, get one of our staff, or go online.
Oh, you undersold it, Paul. I would just say,
Well,
if you're not looking at your market and trying to kiss every need, you're going to run everybody. I'm not saying you, Paul. You and the audience are going to run yourselves ragged. Understanding your market and where the opportunities are, Confer Analytics is fantastic at helping to do that, and it makes you much smarter, much faster.
Amanda talked earlier about having a patient story, right? People love data, and payers want data, and that's great. Don't forget to bring a good story with a good name like Minerva.
Key takeaways. I mean, you could read them up here. What I really, really like is our 3 to 5 meaningful measures that you can prove. To reiterate, Cameron reiterating me, reiterating him, right? And I was going to say, we kind of took out some of the slides because they were a little detailed, but a mixture of process and outcome-based measures. If you have a process that works really well, advanced care planning, maybe you don't build the ACP code, but you have a process of filling out Pulse, or you can track something like that. That's a process measure. Prove that out too. So you can have a couple of those process measures of every patient has a call from a nurse or a social worker within 24 hours of being discharged for the hospital. That's you can say 100% of our patients have that. That's a super cool measure I'd bring to the table as well, because that's going to impact downstream. Cameron?
Oh, I would just absolutely underscore that. The other thing I would add is role assignment and definition is super helpful in a team. And so what we actually did, just to kind of take your point, and we have fun building off of each other's points. We said the social worker on the team. The other thing is if you try to do this and you say, oh, the provider has to do all these screenings and assessments and whatnot, you drown one person. So we said advanced care planning, we're tagging that to the social worker. The team can be involved and help and support, but you got it. And we did a Pizza Hut delivery screen, which is exactly your process measure, which was we haven't initiated is a 0. We've initiated the conversation was a 1. We've initiated the conversation. We have an advanced care plan document that's in draft 3, and we kept going to them. And then there's an order set in place. And that everybody was like a Pizza Hut delivery in process to being ready to pick up your pizza with an order set. Just really a great way to give a specific set of responsibilities to one person and to measure the process measure or track the process measure.
I want to just take this moment to thank our faculty, Dr. Cameron Muir, Dr. Paul Chang, and Amanda Tufano. It's such a pleasure to work with all of you, and I want to thank all of the attendees for spending this time with us. Take some more food and stay in touch with us. Thank you so much, everybody.